Hello. Hello, everyone, and a very warm welcome to this graded motor imagery in the clinic. My name's Joanna, and I'm Director of NOI Europe. And I'm joined this morning by my very good friend and NOI instructor, Tim Beams. Tim has been a NOI teacher for coming up 20 years and has taught GMI to hundreds of clinicians all over the world. Tim is an active clinician himself, specialising in persistent and complex pain. He is also co-founder of an organisation called Le Pub Scientifique, which is an online education platform for clinicians to learn about treating pain directly from the people doing the research and leading clinical experts. Tim, would you be kind enough just to drop that? Thank you, you've done it. I can see that. Well done. The podcast at Le Pub is brilliant. It's a great way to get a flavour of what they do. So these sessions are all about giving you a taste of explain pain or GMI and how to practically use it in the clinic. Now, some of you will have already done a GMI course, and for those of you, these sessions are designed to reinforce what you may have already learned. But if you're new to this material, then it'll give you a taste of what is covered on the core course. So just a couple of things to mention before we start. Tim and I will be talking for about 20 minutes. If you have any questions, please pop them in the Q&A and we'll get to as many of them as we can. And if you want to watch the recording to this session, then it is on YouTube in our clinical discussion group. And I've just dropped the link to that into the chat there. And we'll also email it to you if you've signed up. So you'll definitely get access to the recording. So today we're talking about dosage of GMI across all the three treatment phases. So Tim, can you just give us an outline of what you're going to be talking about this morning, please?
Exactly that, I think.
Well, I hope so. That's what we've said.
Yeah. So I suppose like just a little more detail. So what we're going to talk about, I mean, we'll introduce GMI for those who don't know it very briefly. Talk a little bit about the original protocol and the effects as well, you know, how people trained and what we saw from that. And then pragmatically have a think about the protocol and how that relates to people and to clinic and what have you. And then the question that I think I'm most interested in talking about is around dosage. Like, can you do too much?
Yeah.
Can you do too little? So finding the sweet spot and perhaps we can talk about some of the sort of cues that you're looking out for relating to that, and also talk about what we don't know, because there's obviously stuff that we don't know about. Cool. So yeah, that's okay. What I'm thinking.
I think before we kick off, I should also just mention that Tim is co-author of the Graded Motor Imagery Handbook. So yeah. So if pretty much you are, you know, what you don't know about graded motor imagery isn't worth knowing. So you really know your stuff.
I don't know about that, but
no, you're definitely a leading voice. You did write a book. No, you did. And,
hilariously, someone was on a course with me the other day, and I don't know how it came about, but they said, I bought this new book from NOI. It's called Graded Motor Imagery. Do you think it's worth me reading?
So no,
and I was well, have you noticed who wrote the book? And anyway, so yeah, I should probably tell a few more people.
I've got a copy of that here. Just let me get one out. There we go. Just to show the book.
There we go. Yeah, I'm even on the front cover. Look, there you go.
There you go.
Bottom.
Timothy Beams, although it's getting lost in my thing. But there you are, Timothy Beams.
There we go.
Co-author, GMI Handbook. Brilliant. Okay, so let's kick off. So do you want to just give us a little, for anybody that doesn't know, what is graded motor imagery?
Graded motor imagery is a treatment approach that was designed for really challenging pain conditions. And there are three separate elements, if you want, stages for this treatment approach. The first is called implicit motor imagery and involves someone identifying pictures of body parts and grouping them into left or right body parts. The second element, phase, stage is explicit motor imagery, so imagining doing something or seeing something, feeling something bodily related. So imagining, assuming a posture that you're seeing on a card, for instance, or running through an activity that you might do mentally, but without doing it yourself. And then the third part of GMI is using a mirror to give you visual feedback of the limb. So mirror visual feedback, where you see the reflected image as if you are seeing the one that's hidden behind the mirror. That's how it was designed. Its application looks a bit different for different pain conditions. So it's not, you can't easily do that, use the mirrors, for instance, for back pain. But obviously for complex regional pain syndrome or phantom limb pain, it lends itself really well to. And then there are conditions where we're starting to explore beyond that, like conditions like chronic pelvic pain, facial pain, where again, some of the ways that you apply elements of graded motor imagery, like using the mirror, would have to be a bit different from the original protocol. So yeah.
Am I right in thinking that the the application has actually become a lot broader than it was initially
Yeah, definitely. Yeah,
realized?
absolutely. Yeah, and you know, a lot of that is that people saw the promise in, you know, if you can help someone who is experiencing long-term phantom limb pain or
Mm,
complex regional pain syndrome, that is amazing, because they were and are traditionally challenging conditions to be able to treat and to help someone. So offering some optimism and hope for people with those conditions really is amazing. So if we can then extrapolate out and see where else that might be able to help, stroke. More recently, I've obviously mentioned facial pain and pelvic pain and back pain, but things like people who are immobilized, someone who has movement problems, people who have degenerative neurological diseases as well. So people are starting to apply it elsewhere, rheumatological diseases, etc. So people are going way, way beyond the
yeah,
usage, the original sort of population that was explored.
yeah, that's wonderful. Thanks, Tim. Okay, so let's kick off then with what we're talking about
Should we,
today.
should we, should we say, so the original, and I think this is an interesting thing. So the original protocol that Loz put together was a 2 week phased protocol where each 2 weeks you would devote that 2 weeks to one element, and then you'd move on in the next 2 weeks to the next element and the next element. Within each of those 2 weeks, you also change the way that you perform the task. And essentially, the change was a graded exposure process. So you started from least challenging to most challenging, or least likely to cause pain to most likely to cause pain. And there was this phased process through each stage. And there is, I mean, there's elements of that that are awesome and lots for us to unravel within it. And it's protocolized for a reason. You're trying to figure out whether or not doing something in this way is going to be helpful for another group, or if another group, a research group, applies the same treatment, they're doing the same thing. And what Lorimer found in his original research is that obviously it demonstrated some amazing success
Yeah,
for people, and the people who who experienced success, they were training an awful lot. And his original request was that you train for 5 minutes of every waking hour, which is a
Okay.
phenomenal amount.
It is.
And people were achieving around 70% of that. So the adherence rate to that
Wow.
protocol was phenomenally high. And there's clearly from that, and when I first read and thought about it, I just couldn't wrap my head around people being able to do that. So pragmatically, was that gonna work for my population and the way I work? So that's, I think that's important there. That was a very high requirement,
Mm.
demand on people, incredibly high demand. And you have some groups exploring GMI, and there's a fairly famous study that was written that says GMI is not, I mean, essentially the conclusion was GMI is ineffective for this group. But when you actually then explore the way that they followed the treatment, they did something that was very different and different for different people.
Mm.
And that's interesting. I mean, in that, do we need to follow the protocol as it was originally set out, or can we and should we start to extrapolate out from that? And
Yeah.
actually, we still don't know those answers. So we're still learning from the application, and we're learning from people
Mm.
delivering it in different populations as well. So let's just say, for instance, if someone's lived with a 10-year history of CRPS, would that look the same as someone who's got an acute ankle sprain? Of course not.
Mm.
So figuring out what GMI should look like for different patient groups. So, something like an immobilization phase, someone might be immobilized for 4 weeks. So delivering that within a 4 week period is absolutely appropriate, but is then going to start looking very different from the original protocol. So GMI, coming to your original question, like, have things changed? Yes, they are. And they have to. Is that still GMI? It is, but it's GMI with a different flavor. So
Mm.
yeah, and I think it's important to recognize that, whatever the GMI is that you are delivering is your flavor of GMI. And I think that's a good thing.
Yes, I do.
You should be finding your way with your population
Yeah.
to deliver an approach.
It's always seemed to me, Tim, that GMI is it actually enables people to do that because it provides a lot of different moving parts, if you like, that they can ramp up, ramp down, and incorporate into a personal way that they're treating one patient. It's very, very flexible. And this is what I've come to understand over the years, that it's an incredibly flexible treatment protocol.
Yeah, I mean, maybe that was partly my fault because I always wanted to be more flexible because I hate the rigid
Yeah, but that's a good
saying those
thing. This is a
combined.
good thing.
Uh, but then so what I wanted to just touch on is that then there are considerations. So things like we just mentioned about time in terms of how long someone's experienced things for, but there are life situations as well. What sort of support someone has, the
Mm.
finances, whether or not they're working or not, whether they've got young kids. I mean, there are so many different elements that make it more or less doable as a treatment approach, and finding the way to what makes sense for that person is important,
Mm.
even including them understanding what it is that they're doing. So if someone has no idea, I'm looking at pictures of body part, and I've heard this many times. I was told to do this thing where I'm looking at pictures of bodies. I've got no idea what's going on there. It's
Yeah.
important for someone to know, like, why is it that I'm doing, or why is it that I'm doing that?
Mm.
And then And then there are elements which could be, I think, really interesting, and we haven't quite got this, is the nature of profiling relating to something like how plastic something is, how changeable someone is. And I think there will be certain people that will need to do an adjunct with GMI that means that you create a sort of ripeness for plasticity. But I don't know exactly what that will be. I've got some ideas, but then, and that is wrapped around ideas of, I mean, at the very basic level of what we talked about of understanding and support, but I think it probably will be a bit more than that. So what's the role of
Mm,
maybe drug management or surgery, or so what, and putting that in with it will be an important feature in the future.
yeah. Okay, cool. Um, okay. So where do you sort of get started with the dosing
Yeah,
then?
I think that's a nice question, actually, isn't it? I say to people, what we know from the evidence and working with someone is the more you do, the more effective things can be. And I said about the 70%
Mm,
adherence rate, and there's a little bit of audit data from Loz's patients, 160 patients, which is really interesting, where he demonstrated that something like 40 people had a one or less reduction in pain. Of those, only two performed seven or more sessions per day of the first two elements of GMI, so the
mm,
implicit and explicit motor imagery. Um, 70 people had an improvement of three or more points on the numerical rating scale, so a 10-point scale of pain at follow up. I think it was 6 month follow up for this. Um, only, or I think it was something like only five did less than seven or more sessions per day of the first two
mm,
phases. So it looks like, what is it, like seven's the magic number. Um, but
mm.
it looks like the more you do, the more possibility or opportunity there will be for change down the line.
Wow. That is. So what's been your experience then with your patients of this?
That's a hell of a lot, asking someone to commit to that. But some people, boom, no problems at all. And I've had a bunch of, I mean, you can, for instance, you can see the data for their recognized scores for the judging the left and the right.
Yeah.
And some people can do thousands and thousands of tests. And I'm not exaggerating there. I literally have seen like thousands of tests in a couple of weeks. So people can do that. But you have to be in the right place there. And the certainly the component of GMI that I've seen people do the most is the recognized, because it's sort of to hand, isn't it? Yeah.
Yeah. Do you,
Um,
do you think that there's an element of do you think that people enjoy doing it?
I wonder that. I wonder whether you need to enjoy it to be able to commit to it, but I don't know whether that's necessary. I think you need to find ways of creating habit around doing a test and making it doable as well. So
Mm,
I spend a lot of time with people pragmatically going through that. So I might say to begin with, what we know is you need to do more, or the more you do, the more effective things can be. But it also needs to fit into your life. So how are we going to do that?
mm,
And that then is where I'm starting. is figuring out how we put that into someone's life, and
Yeah.
coming to sort of my, and I am me, but whatever Tim's flavor of GMI is not a protocolized. Let's do 6 weeks, 2 weeks, 2 weeks, 2 weeks. Mine is okay. What does GMI look like for this person, given their life situation? And we work very individually in terms of creating something that's meaningful and doable for them.
Yeah. Um, Joe Thorpe's just asked a great question. What resources are currently available to support GMI practice, please? I think there used to be a website that patients could access. I think it's used to keep a score of their time.
Well, I
Is that
mean,
the Recognize app?
yeah, you can connect with your clinician, so they just need to drop your email in, and you can connect via that. I personally, the easiest way is I actually create some sort of accountability over a process, and this is treatment in general. That looks like it's very different for everybody, but it might be something like a check-in via WhatsApp, share a picture of what's going on at the moment, and a
Mm,
little bit of feedback. So that's personally how I do it. Yeah, other resources, I'm not sure. Yeah.
So there is a, I mean, that is the Recognize app is used for the NOI has created an app, haven't they,
Mm,
called Recognize,
yeah.
and that is used for patients to log their um, dosage. Is that right?
To practice, yeah, to
Yeah,
practice, and then you can see the results, yeah, and then there are
yeah,
different elements within that you can vary. So you can either play some games, or you can change the time that the pictures are shown, so you could be more explicit in the task as well. So
yeah,
there are different features to the app. It's also not the only app available. There are other people obviously jumping on that, and but they give different data, it looks like, and the data, I don't can't quite make sense of the data because it doesn't fit the scientific way that we would extrapolate, or that it's
yeah.
been extrapolated, and therefore that we can make sense of it. So yeah, it's not very understandable for me, but it might be for other people.
So
Yeah.
because NOI does have like the full set of resources for GMI, so you could obviously there's the handbook that we're just showing you. It's got the flashcards, so the physical flashcards for people to do the visualization, and
Yeah.
it's also got mirror boxes as well. So and the app, the Recognize app, which is the logging app. So
As if we
NOI
came
does provide the
prepared.
full. Oh, you've got a set, yeah.
Look at that, right on
So
the desk.
we
Yeah,
don't
there
ever
you
really
go.
normally do this on a session, do we? We don't normally do product placement, but actually, GMI is
So we go.
Noi have created everything. Oh, there's us. They've created the
The
whole
mirror
package of
box. There we go.
resources for using it with your patients. The thing that Tim and I always really focus on in these sessions is Tim's the educator, and it's really about helping people to understand how to use those kind of resources. You don't have to buy them from Noi. You can make your own if you like. But what Tim
Yeah.
brings is the expertise in actually how to create the treatment plans and protocols to work with your different types of patients. I have got a question though, Tim. Is can you ever overdose
Yeah. Great
on the
question. Great question. Can you
treatment?
overdose? And before we came on, I said my patient last week emailed me or texted me to say this, didn't she? And
Mm,
so she said something along the lines of, "Is it ever possible to do too much?" Brilliant question, isn't it?
yeah.
So the answer is we don't know. But looking at that audit data, it looks like you need to do a lot.
Mm,
So, and from a learning perspective, that makes absolute sense. So, actually doing repetitively over a 6 week period, this fits like a learning paradigm. So in order for you to create the conditions for plasticity and for plasticity to be maintained over a period of time, or learning and change to be maintained over a period of time. Like a 6 week period is a very common period for people to follow. But my thoughts would be that you can always overdose. You can also underdose
Mm.
as well. And perhaps we know more about underdosing than we do overdosing. But it looks like, I mean, again, just extrapolating Loz's data, I don't know for sure, but there was a few people, 5 people that, perhaps they were overdosing and they,
Mm.
as a result, they weren't so good. But perhaps there were people within that group that were underdosing and they needed to do more. But I think dosage is an important consideration for us, and Lorimer had that in his original protocol, which is why he created the graded exposure process. So it is important that I totally believe this, and I feel this sort of liberated a lot of my thinking, was that I was creating a condition, and the condition that I feel safest is the safest, is creating safety and comfort and calm, and like, why not do it sort of under the radar, we used to call it. So why not do it in a way that feels right and comfortable, and you could do more. Not that I'm
Yeah.
pushing myself so hard that I feel, I'm exhausted or I'm flaring up, or so I'm trying to create in my patients to begin with, I'm trying to create a condition where we're saying, I want you to be able to finish and feel like you could have done a bit more.
Yeah.
And then we're going to start challenging you. And challenge needs to be put in at a time. You can habituate and you can learn to do something in a fairly distinct way. But if you keep doing it in exactly the same way, you're going to start losing the potential for learning and change. So we do need to put something new in there, which was
Yeah.
always a part of GMI. And that's why it was so wonderful. But there
Mm.
will be a time where you need to say, okay, we need to do a little bit more, or we need to do it slightly differently. And I think we've talked about this previously, and one of the problems that I had with GMI is saying, let's do 2 weeks of one phase and then stopping it and then starting something new, because you might still reap the benefits of doing something alongside. So you might continue some implicit motor imagery whilst introducing
Mm.
explicit motor imagery, and that might be in itself a nice challenge to the system and to the organism, and to sort of create that right condition for change as well.
Yeah.
And
I've
then
just
an
got, oh,
element of
sorry.
the understanding, sorry, Joe, now you've got me going, but an element of the understanding is not just understanding the process, why am I doing it, but it's understanding and reading yourself as well. So someone being able to listen to themselves, to listen to their body and know that either they're doing it right, or they're doing too much, or they're doing too little. And I think
Mm.
that's a very important skill that you might be developing during your treatment.
Yeah.
Not everybody knows it, and there's a lot of, if you think about the boom and bust cycles that people get into, the requirement to begin with is just to recognize that, see it for what it is, and think, okay, I've tried that path already, so I might need to try something alternative that might mean, starting to even out and level out things. So,
Mhm.
so I think you can overdose. I think you can underdose. I'm pretty sure of it. And there are sort of things that you hear from people. People will say things like, "I haven't found time for it," or I can't see the point." Or I had a brilliant a start of a conversation the other day, which was, "I feel like a naughty boy." I feel like a naughty boy. You're going to tell me, it's like, you're going to tell me off for not doing enough or whatever. But my personal approach is not to tell someone off, but is to see, is what we're asking of you realistic as well,
Mm.
and achievable. So we used to talk very much about that. They were very key messages with the start of us teaching GMI, was it was key to have a realistic practical application of it, and once you found that, to create some persistence and some patience in that process, because change does
Mm,
take time.
mm. My final question, just before we finish up here, Tim, is you're a very experienced clinician and you deal with a lot of complex cases, but you are. How important has graded motor imagery been in your clinical practice?
Oh, that's cool. Well, I think coming to it and having to learn about GMI, so the different elements of where, because Lorimer, I mean, the phenomenal depth of where he's brought information and knowledge in
Yeah.
is incredible. And that was amazing for me in my career, is to start looking outside of, if you want, traditional rehab realms and physiotherapy, as I sort of came from.
Mm,
Because there's awesome areas around exposure in vivo, operant condition, etc., that I started to go into, and then learning about environmental enrichment, and like there was so whole areas that I still feel that we probably haven't quite realised the potential of yet in the rehab sciences.
and how often are you incorporating it in your clinical practice?
Well, I incorporate that thinking every day.
Mm,
I don't have patients that are working on left-right judgment or explicit motor imagery or mirror therapy with me every day, but there are people using these techniques away from me.
yeah,
I'm absolutely sure every day. Mm.
yeah. Okay, that's brilliant. I think that just brings us back round really nicely to the fact that it's so flexible, and you are using even the small elements of it in your daily work with your patients. And that's the thing that's always struck me, is that it started as something which we thought was quite niche, but actually it overlays so much of what you're doing in the clinic.
Yeah, I wonder what it would be if it was designed now, what would we call it? Graded motor imagery? Would it be
No,
protocolized in that way? What's so, but it's happened now. So,
yeah, it has the
it's like
name.
GMI 2.0 or 3.0 now, isn't it? And
Yeah,
that looks very different from GMI 1.0.
a lot of what they call it, what is sort of being referred to more now, is like brain training, isn't it? And that's a kind of, like a more accessible title, whereas GMI is a little bit like what? But anyway, it's got the title now.
Bullshit. Right. It's not brain training, because that dismisses the importance of the body in it. So,
True.
I think that we should definitely ditch that and move,
Mm,
unless the patient wants to call it that. But otherwise, we need to, it's much bigger than that.
yeah, that's cool. Thanks, Tim. Brilliant. I love talking to you about GMI. Just sort of do. So just to wrap up there, Tim, if anybody hasn't done the course and is interested in spending 3 half days with Tim to learn about graded motor imagery in its broadest terms and how to use it with your patients, then and all the practical techniques that we've talked about very briefly here today, then Tim has got an online graded motor imagery course coming up on the 4th, 5th, and 6th of December. We find that the online course works exceptionally well for this as a delivery method. Tim, could you just very quickly just share anything about the course that you'd like to share? Not specifically this one, just how much the sort of people that come on it, or uh,
Yeah, a real mixture of people. I mean, I guess the only thing you haven't really said there is we have an opportunity to discuss and talk about, specifically the populations that you work with and how you might
yeah,
apply things. So I think that's important.
yeah, yeah. So if you're interested in that, then we'll send the link out to the course in the email with the link to this recording as well. I think we've got about 8 places available on the December course. So if anybody does want to jump on that, then the link will be sent out to you. So thank you so much for joining live with us this morning or this evening. And we hope you found it useful, and we'll see you again really soon. Thanks a lot.